look for deviation from the midline, and if goiter is large or bilateral, perform the Coker's test. Lastly, palpate the carotids behind the posterior border of the swelling. Now let us proceed to percussion and auscultation. Percuss directly over the manubrium sterni or use a heavy percussion stroke. Normally the note is resonant due to air in the trachea behind the manubrium sterni. If the percussion note is dull, suspect a retrosternal extension of thyroid, which descends between the trachea and the sternum and comes to lie between the manubrium sterni and the air column. Auscultation. Auscultate over the swelling, paying more attention at the upper poles for a systolic bruit. Bruit is diagnostic of primary toxic goiter and is due to markedly increased vascularity of the gland. Having completed the examination of the swelling and concluded that it is a thyroid swelling, now you should look specifically for signs of thyrotoxicosis, signs of myxedema, signs of retrosternal extension, and signs of metastasis. Signs of thyrotoxicosis. First, let us look for the eye signs. Ask the patient sitting upright on a stool to look horizontally forwards towards a distant object at eye level. Normally, the lower lid just touches the limbus at 6 o'clock, while the upper lid covers the upper margin of the cornea from 11 to 1 o'clock. Limbus is the corneal margin. The early eye signs of thyrotoxicosis are lid retraction, lid lag, and infrequent blinking. The earliest eye sign to appear is the lid retraction with resultant widening of the palpebral fissure, also termed as Dalrymple's sign. Note here the lid retraction which is more prominent in the left eye. The upper lid is retracted due to tonic contraction of the involuntary part of the levator palpebrae superioris, thereby exposing a strip of white sclera above the superior limbus. This results in a typical staring and frightened look of a thyrotoxic patient. This is associated with infrequent and incomplete blinking of the eyes, termed as Stellwag's sign. Note how infrequently the patient blinks, and when she blinks, it is only partial. Now test for lid lag or von Graff's sign. With the left hand, fix the patient's head to prevent neck flexion or extension. Hold your right index finger in front of the patient's eye at a distance of 40 centimeters and asking the patient to follow the finger, move it upwards and downwards. When the patient looks downwards, the upper lid lags behind and a larger portion of the white sclera is exposed on looking down. This is a positive von Graff's sign. With further progress of thyrotoxicosis, there is actual bulging of the eyeballs due to retroorbital edema and fat deposition. This is termed as exophthalmos. Ask the patient to stare horizontally forwards, and a strip of white sclera is visible between the inferior limbus and the lower eyelid. This has nothing to do with the upper lid retraction, and it is due to actual forward bulging of the eyeball, that is exophthalmos. Now to note the amount or degree of exophthalmos, examine the eyes by Nafziger's method. Stand behind the patient, tilt the head of the patient backwards to observe the eyes in supraorbital plane. The actual protrusion of the eyeballs beyond the supraorbital ridges can be appreciated in this position. Normally, the eyes do not project beyond the supraorbital ridges. Now ask the patient to look upwards with head tilted slightly downwards. Look for the transverse wrinkles over the forehead which are seen in a normal individual in this position. Absence of wrinkling of forehead in thyrotoxicosis is positive Geoffroy's sign. If the exophthalmos is limited to one eye, it has to be differentiated from proptosis due to an intraorbital mass. Ask the patient to look downwards and evert the upper eyelid. The eversion is difficult or impossible in exophthalmos due to thyrotoxicosis, while in a case of intraorbital mass, eversion is possible even with very marked proptosis. This is the Gifford sign. Now test convergence by holding your finger at a distance of 1 meter from the eyes and asking the patient to stare at it. Now bring it slowly towards the midpoint between the eyebrows. The patient cannot converge the eyes in exophthalmos. This is a positive Mobius sign. Convergence is slow, jerky and incomplete. With progressive exophthalmos, there is further bulging of the eyeballs with conjunctival congestion and edema. In a later stage, there are corneal ulcers, diminished vision and ophthalmoplegia or restriction of the eyeball movements. To revise, look for lid retraction, lid lag and infrequent blinking. Look for actual exophthalmos by Nafziger's method and visibility of sclera beneath the inferior limbus. Then look for wrinkling of forehead, that is Geoffroy's sign, and test convergence, that is Mobius sign. We are examining for the signs of thyrotoxicosis, and we have now studied the eye signs in thyrotoxicosis. Next, look for fine tremors of outstretched hands and protruded tongue. Ask the patient to stretch out the arms with slight fanning of the fingers. Thyrotoxic patients will always show a fine tremor of the fingers. This is another patient with a thyroid enlargement. Note the fine tremor of the fingers of the outstretched hands suggesting thyrotoxicosis. Another method to demonstrate tremors is to keep a piece of paper over the outstretched fingers. The vibrations of the paper are more easily appreciated. Then ask the patient to open the mouth fully and put out the tongue straight for 15 to 30 seconds. The tongue should not touch the teeth. Look for frank tremors or in mild cases fine fibrillary twitchings. Note again the tremors of the protruded tongue in thyrotoxicosis. Next, feel the radial pulse. Tachycardia and bounding pulse are characteristic of thyrotoxicosis. However, pulse rate may increase further due to anxiety which is associated with thyrotoxicosis. So, to judge the degree of thyrotoxicosis, you must count the sleeping pulse rate, which is counted early morning around 4 am, that is before the patient wakes up without disturbing the sleep. A fast and irregular pulse may suggest atrial fibrillation. Now feel the palms and feet of the patient. In thyrotoxicosis, they are warm and moist, and the legs may show pretibial myxedema with thickened hyperpigmented skin and coarse hair. Lastly, another characteristic sign of thyrotoxicosis has already been studied by us during the examination of the goiter, that is, the palpable thyroid thrill and thyroid bruit on auscultation. Let us remember here that in primary thyrotoxicosis, the eye signs and tremors are more prominent, while in secondary thyrotoxicosis, cardiac signs are more prominent with tachycardia, cardiomegaly, atrial fibrillation or congestive cardiac failure. In secondary thyrotoxicosis, the tremors are less prominent and eye signs and exophthalmos are not seen. Signs of myxedema. If there are no signs of thyrotoxicosis, look for signs of myxedema. Is the voice hoarse? Is there edema of the face and legs? Does the patient feel lethargic? And look for the diagnostic clinical sign, that is delayed relaxation of the deep reflexes. Test the ankle jerk and the knee jerk. Note the typical myxedema faces with edema and dry, coarse skin. and listen to the characteristic slow hoarse voice. Now note the slow relaxation phase of this ankle jerk. The muscle contracts briskly as usual and then relaxes slowly. In this early case, note the slightly delayed relaxation phase of the ankle jerk. Now we look for the signs of retrosternal extension. Inspect the upper chest, neck and face for dilated veins, congestion and puffiness, which result from pressure on the internal jugular veins at the thoracic inlet. Palpate the tracheal rings in the suprasternal notch. Inability to palpate the rings suggests a retrosternal goiter. Then percuss over the manubrium sterni. A dull note instead of normal resonant note suggests the presence of a retrosternal goiter. Now elevate both arms above the head until they touch the sides of the face. Hold them there for 1 minute. If this maneuver produces congestion of the face and respiratory distress, it suggests thoracic outlet obstruction, which in case of a goiter is most likely to be due to retrosternal extension of the goiter. This is positive Pemberton's sign. Lastly, look for Horner's syndrome, which can occur in a retrosternal goiter or in a malignant goiter affecting the cervical sympathetic nerve. The features of Horner's syndrome are ptosis with constricted pupil and enophthalmos in the eye of the affected side. The ciliospinal reflex is lost and there is anhidrosis or loss of sweating on the affected side of the face. Lastly, look for the evidence of metastasis meticulously if carcinoma is suspected. Palpate the neck on both sides for enlarged, hard lymph nodes. Palpate the entire skull surface for hard nodules. Look for bony deformity or tenderness in long bones. Examine the abdomen for nodular liver and ascites. And examine the chest for signs of effusion and consolidation. This concludes the clinical examination of a case of thyroid swelling.